Welcome to Fundamentals, Chapter 38, End of Life Care. A terminal illness is defined as recovery from this condition is beyond reasonable expectations, meaning that a patient has no means or no hope of getting any better despite any life saving or heroic measures that we provide. There is no recovery expected for this client. That is a terminal illness. Advance directives are legal documents that direct end of life issues. A living will is a directive document for medical treatment per the client's wishes. Then you also have what is called a healthcare proxy, or in some states is called a durable power of attorney for healthcare. And then this is a document that appoints someone to make medical decisions when the client is no longer able to do so on their own behalf. Types of loss are experienced by the client themselves, caregivers, family members, and even staff members who are caring for the client. And it is a necessary loss. We have actual loss, perceived loss, developmental loss, situational loss, and anticipatory loss. And like I said, the client will experience these types of loss as well as caregivers and even staff taking care of the client. So Kubler-Ross, she wrote a book back in the 80s about the stages of dying. We have denial, anger, bargaining, depression, and acceptance. So a client's going through the denial stage. They refuse to believe the diagnosis and hope that it was a mistake in the report. So we just deny the client denies it. They don't want to believe it. They just don't believe it. They refuse to believe it. My family members can feel the same way too. Anger is the second stage in death, in which the client retaliates by displacing his anger on his caregivers, his healthcare providers, or even God. They lash out, complaining about care, may be a result of a client experiencing anger stage and dying. You may see that. It's very emotional response to feeling when they feel victimized, and they just retaliate against everyone. It can be against you. You're the caregiver, and they have no one else to yell at or complain about or to be angry at. But it's a stage. It's a stage that they have to go through in this process of dying. So you just have to be aware of that when you're dealing with someone who is experiencing death. Bargaining, that's the third stage. So try to delay the inevitable. So you try to make a deal with God or your higher power and say, if I do this, will this happen? I'll do anything not to die. I'll do anything. I'll make a bargain with you. It's a delaying the inevitable, but that bargaining stage, you'll see some of that. Depression, that's our fourth stage, and it's a result of confronting potential losses. They know that they're in the process of that death is inevitable and that is going to happen. And they're just sooner than later. They just are, it's coming quicker than they want it to be. And so that depression sets in. They become withdrawn from their family, withdrawn from their caregiver. It's a natural phase to go through. And then acceptance. So acceptance is an attitude of complacency, and that occurs after the client has dealt with their losses. So they've gone through those losses that we had discussed about in the previous slide. They've gone through that loss mechanism, and now they're in the acceptance. And so we as nurses have to promote that acceptance. We can help the client to pass from one stage to another by providing emotional support and supporting the client's choice regarding their terminal care. It's ultimately up to the patient, especially if the patient is cognitive, on how they want to proceed with their care. And promoting acceptance is our part in the stages of death. So, like I was saying, promoting acceptance is a emotional support, part of missing in nursing care. You don't see a lot of that. A lot of people are very uncomfortable with death and how to support the client and support the family. It takes a little bit of practice and a little bit of just practice in how to interact with this particular situation that's happening. During this acceptance phase, you may see a lot of life review and reminiscing. That's very characteristic of an older person, especially during the acceptance stage. So you want to be an active listener for both the client and the family. Listen to them. You don't have to say a whole lot. It's just a matter of listening, and that will help with that acceptance. Talk with the family, arrangements about care. Be very respectful of a client's right to die. The nurse during this time period, you can ask the client if they want to meet or thank any loved ones, if they have anything particular they want to say. You can also help the client to maintain their dignity at all times. Like I said, providing that emotional support the client's choices for concerning their terminal care. Provide those opportunities for the client to express his or her feelings as they demonstrate attention to meeting individual needs. So whatever the individual needs are of that client, make sure that you are addressing those needs, not just of the client, but of the family too. Trust me, it's an all-encompassing situation when you have someone who is in the active dying process. So lots of times the arrangements for care for the terminal um, client is the responsibility of the nurse, and we look for home care or hospice care. Most of the time, it's one of those situations. Home care, if we send the client home, we want to make sure that the family or the caregiver does have someone who can come in and give them a break. If a client is eligible for hospice, which means they have 6 months or less to live, if they qualify for hospice, hospice will come in and perform some home services, and sometimes it's a multidisciplinary team of hospice professionals and volunteers who provide that support for the family. Know that hospice can be terminated if the client no longer meets Medicare criteria, if they survive beyond the 6 months. However, if a doctor certifies that the client continues to meet hospice criteria, they may continue to get hospice care. And a lot just varies from state to state. But for the most part, hospice can be for the terminal, long-term care patient. So as nurses, how do we provide this care to this terminal patient who's going to be passing away? Well, we need to maintain hydration, nutrition, elimination, hygiene, position, the respiratory, and comfort measures. Comfort measures, the goal of treatment is for a comfortable, dignified death. Further life-sustaining measures are no longer indicated. Dying with dignity means that the process by which the nurse cares for the dying client with respect, no matter what their emotional, physical, or cognitive state. So even if that client is in that anger stage, you still need to be respectful and provide them care. Care for the client with respect, regardless of their current state. Regardless of how they feel, you need to provide them with care. They need the right to die with dignity. So we can give them proper fluids when they need it. If they wish to eat, we can feed them. If they need frequent linen changes or catheterization, we can do that. And at this point, does it matter if the client's going to have a UTI? It really doesn't. It doesn't matter. If the family wants them to have a Foley, put in a Foley. I mean, it is at this point, it really doesn't matter. But we have to keep the client clean, well groomed, make sure that they get a bath every day, position them every couple of hours. You still want to turn that patient, even though we know that their end is going to be near. We still want to turn them and give them comfort. Put them in a sitting position. Keep your activities to a minimum. You want to make sure you cluster your activities so that you don't wear the patient out. Give them some supplemental O2 if that makes them feel a little bit better. It's not going to sustain anything or prolong their death. You can also get a small fan. Sometimes that makes them feel a little bit better just to have that air circulating. And by all means, keep the client pain-free. That is a prioritization, is pain control. Keep that client pain-free and offer them emotional support. Do not be afraid to administer those narcotics. And if the client says, well, I don't want to be addictive, I don't want to get in that habit of addiction, you say, listen, I'm going to control the schedule of your pain medication. We're going to space it out so you're not getting it all at one time. And there's really no chance of you developing an addiction at this time. We're just going to give you some comfort by giving you this pain medication. So don't be afraid to give that medication. And also reassure the family too, since addiction is such a big thing in the news now. We need to let the family and the client know that we have no fear for them at this time of having any addictive behavior. So how do you know that someone's on their deathbed or on their way to an impending death? How do we know that? Well, there's certain things that we look for as nurses when we go in and we're doing that physical assessment and we're in with our client. There's certain things that we are going to look at and we're going to notice to see how rapidly that death is coming. So we look at their heart. Do they have a low blood pressure? They're experiencing any hypotension? Is their pulse irregular or weak? Is it rapid? What does their skin feel like? Are they cold, clammy, mottled? Mottled is a purplish, blanching type situation that occurs in a lot of people who are in the process of dying. And you see that a lot in their extremities or in their trunk. You'll see this mottled skin is what it's called. Do they have any bleeding going on or have any bleeding in their gums? Are they experiencing any edema, any jaundice, impaired digestion, any abdominal distension, some anorexia or nausea, vomiting? That could be related to their liver failing. What do their lungs sound like? Do they look like they're short of breath? Do you hear fluid or that death rattle sound? It's a gurgly type sound. Once you hear it, you'll always remember it. You'll know what that death rattle kind of sounds like. Urine. Are their kidneys functioning? Are they having any urine at all? In their brain. So believe it or not, a neuro fever or a neuro failure, that brain is brain death, Those clients will have an extremely high fever. I mean, I'm talking 105, 106. We see that in someone who is in brain death. Does the patient have any confusion, disorientation, um, hypoflexuria, any stupor, or have they lapsed into a coma? Are they totally unresponsive? So whenever we're looking at these things, we can see if they're experiencing any of this multi-organ failure. So low blood pressure, low urine, bowel incontinence, loss of reflexes, Cheyne-Stokes breathing, Cheyne-Stokes respirations. Are they experiencing those type of respirations, those Cheyne-Stokes respirations? These are just some signs of multi-organ failure. So sucking is one of the last reflexes to disappear as death approaches. So you can provide a moist cloth or wrapped cube of ice for the client to suck on. Eventually, the client may need IV fluids, but lots of times that's not given depending on the advance directive that's written. And lots of times, clients can find eating to be totally exhausting, to the point that where they may not even take water or juice or anything liquid because it's just too exhausting for them to even take something that simple. Clients who maintain their mental capacity even as they go through any of this organ failure, as long as they have their mental capacity, they have a right to refuse any care. So family is just as important as the client when it comes to a dying situation. You want to encourage that family involvement, maintain those family bonds to help coping with future grief. As death approaches and multi organ failure starts to set in, and you start to see two or more of those organs cease, you have that multi organ failure, you need to notify the family and let them know that death is imminent. And if the family decides that they want to come into the facility or come to the home, wherever it may be, you need to allow for that. Make sure that you meet with relatives and promote that smooth transition. If there's to be organ donation, that's handled from an outside agency at most facilities, and I'll get to some of that later. So when we're talking about family, make sure that you have very flexible visiting. Allow family to come. Allow them to even care for the client if they wish to. But you also need to be able to give them breaks. So make sure you encourage the caregiver to find volunteers or to reach out to other people to come in and give them some relief, to allow that primary caregiver some breaks away from the home, because it can be very stressful whenever you're the only family there taking care of the client, especially if it's a hospice at home. So as nurses, we need to just make sure that we're there to educate and assist as needed in the decision process. If the family has any questions on what can we help them with, and we need to educate them on what they can expect after terminating care. So whenever we remove someone off of a ventilator, we let the family know that death may not occur immediately. It can take anywhere from a few minutes to a couple of days. So we let the family know that ahead of time before we remove someone from a ventilator. We also reassure the family that their loved one is going to have some constant nursing care and will also receive pain medication continuously, so they don't have to worry about any type of suffering during the dying process. So we just have to make sure that we educate the family, let them know what to expect whenever we see one, two or more of those organs that to shut down. We notify the family immediately, let them be part of the dying process, and let the family know what to expect. So death is confirmed by the absence of breathing and circulation. You confirm this by auscultation of breath sounds and lung sounds, and that's usually, if not always, done by the doctor to confirm death. Brain death, on the other hand, is an irreversible loss of function of the brain. So that means that the brain is not telling the body to breathe, or the brain is not telling the body to circulate the blood for circulation and the heart to pump. So the brain is not functioning. Someone who is brain dead can be maintained on a ventilator, which breathes for them, and by the injection of medication to keep the heart pumping. But the brain may be dead. The cause of death is written on the death certificate by the pronouncing physician. Permission for an autopsy. An autopsy is examination of an organs and tissues of the human body after death. Now, in the state of Georgia, if a person comes in through the emergency room and they have been admitted to the hospital and they die within the first 24 hours of admission to the hospital, we have to call the county coroner and ask them if he would like for an autopsy to be done. It's called a coroner's case. We ask them if they feel that there is a need for an autopsy. So we give a lengthy detail of the patient's history and their probable cause of death, and the coroner will decide if an autopsy needs to be done or not. Now, if the autopsy does not need to be done, we don't do it. However, if a family member wants an autopsy to be done, they have to pay for that out of pocket. And it's expensive to have an autopsy done, and so most of the time they won't. But if the coroner says so, we do so. At the time of death, here in the state of Georgia, we call what is called lifelink. Lifelink will assess the patient's death and circumstances of death and their history to determine organ donation. So if it's a regular death with breathing and circulation loss, they can still harvest some organs, especially the corneas. Corneas or some other organs can be harvested within a few hours after death for transplant. And corneas can be donated by clients by age. If the dying client meets donation criteria, they can donate those cornea. When you have a brain death, that person is maintained on the ventilator. When we let the family know that their loved one is brain dead, they have the opportunity at that time to discuss with us organ donation. But we do that through LifeLink, and the organ procurement nurse actually comes and talks to the family about organ donation. If it is a brain death, that patient will be taken to the operating room, and the organs are harvested there by the organ team that comes and flies in to harvest those organs. So, like I said, with the autopsy, we have a clinical autopsy and a forensic autopsy. The clinical autopsy is an examination of the organs and tissues of a human body after death. It is not necessary after all deaths, but it can be useful in determining more conclusively the cause of death. Then your forensic autopsy is a medical legal examination to determine if a crime has been committed. A forensic autopsy does not require permission from next of kin. So this is why we would call the county coroner, and they would determine if it was a forensic autopsy if they needed the cause of death. I have sent a client for a clinical autopsy after they had the ingestion of some WD-40 liquid. So they actually had a clinical autopsy for that client. As nurses, we are um, responsible for performing postmortem care. So we're going to clean and prepare the body for viewing by the family, make sure it's properly identified, and release the body to the funeral home. So there are 5 steps that you need to know for performing postmortem care. The first step is to make sure the provider has confirmed or certified the death. Step 2, verify organ or tissue donation status. Step 3, remove medical equipment from the patient, if no autopsy. If the patient has to go for an autopsy, all medical equipment must be left in place. Step 4, clean and bathe the body, use precautions. And then number 5, attach identification tags. The nurse should clean any secretions and drainage from the skin. Dentures should be replaced in the mouth as they maintain the natural contour of the face. A small rolled towel is placed beneath the chin of the client to keep the mouth closed if needed, if they can't keep it closed. And then you should remove all hairpins and clips if there's any in the hair to prevent any accidental trauma to the face. So everyone grieves differently, and you have to be prepared for those grieving family members, no matter what shape, size, form you get them in. Grieving is a process of feeling acute sorrow over a loss. Although reactions to grief and dying are very similar, the stages of grief reactions overlap and vary among individuals, so it's very individualized. Each person is different, and family members may be different reactions at different stages in the grieving process. So a family member can show signs of resolution of grief if he or she is able to talk about the deceased without becoming overwhelmed or emotion. You know they finally have worked through that grieving process when they get to that resolution stage, and they can finally control those emotions and talk rationally about the situation. But know that everyone grieves differently at some different stage and process and level. So, death and the dying process is a very difficult topic for some people to discuss. And but with that, I want to just encourage you to go out of your way and take some extra time with your client, take some extra time with your client's family. Get that box of tissues, get them something to drink, get them a snack, offer to sit with the client so that they can step out for a minute and get some fresh air. Just take a few extra minutes and spend with your client and their family. Um, there's no harm in showing any emotion during the dying process. I, as an ICU nurse, as many years as I have, I've come to show some emotions with my clients, give them hugs, give them some extra pillows and blankets, and just be as attentive and an active listener as possible. I have shed some tears right along with some of my family members, and I'm not afraid to say that. Um, I'm, I'm a human, and I believe in showing that kindness and compassion during that phase and that stage of death that your client and that family is going through. These are just some of the nursing implications that you may see throughout the process. Um, and so this is a great video. It's called the pause.me. This is an introductory video here. I highly encourage you to look at this video. I was very moved by this video. It spoke to me. It is giving that person who has just come into an emergency room and has died a tragic death, where the whole staff in the room stop and they pause and they give um, some reverence to that person who has passed away. It's an excellent example of what we should be doing as nurses in that respect. We should be given to those who have died and giving them dignity. The Wit movie is also an excellent movie. It's a short film on death as well. So take a few minutes and just look at these videos and let me know what you think. Thank you for joining me today in this very somber, yet very necessary chapter in fundamentals, the end of life care.